The respiratory system is the ventilation system of the body. Its function is to supply the body with oxygen and remove carbon dioxide that is a byproduct of metabolic activity. There are four processes involved in respiration: pulmonary ventilation, or breathing; external respiration, or the exchange of gases between the lungs and the blood; the transport of the respiratory gases in the blood; and internal respiration, or the delivery of oxygen to the tissues. Because of the respiratory system's structure, it's also involved in our sense of smell and speech. Structurally, the respiratory system can be divided into the upper respiratory system, which houses the nose, nasal cavity, and paranasal sinuses, and the pharynx, and the lower respiratory system, comprised of the larynx, trachea, bronchi and bronchioles, and the alveoli of the lungs. Functionally, we can divide the respiratory system into the conducting zone, which is all the passageways from the nose to the bronchioles. It functions to warm, moisten, filter, and conduct the air. And then the respiratory zone, which is the actual site of gas exchange. These are the final bronchioles, alveolar ducts, and alveoli of the lungs. These are the microscopic structures of the lungs. If we look at the anatomy, we have the nose and nasal cavity, the pharynx or the throat, the larynx, the trachea. The trachea will divide into the right and left bronchi, which will feed air into the right and left lungs. The lungs are housed in the thoracic cavity, and the diaphragm separates the thoracic cavity from the abdominal cavity. The nose, the nasal cavity, and the paranasal sinuses act as airways for respiration. The nose and the nasal cavities moisten and warm the air. The nose and nasal cavities are lined with mucous membranes. These are blood-rich, which is where we get the warmth for the air, and the mucus helps moisten the air. Additionally, things like nose hairs filter the air, and mucus acts to trap materials that may come in, so the air is cleaned. The nose and nasal cavities also act as a resonating chamber for speech, and because the olfactory receptors are housed in the top of the nasal cavity, this is where our sense of smell is located. The paranasal sinuses are hollow areas in some of the bones of the skull, the frontal, sphenoid, ethmoid, and maxillary bones. These serve to lighten the skull. Rhinitis is a common inflammation of the nasal mucosa. Most commonly caused by cold viruses, it can also be caused by bacteria and allergens. Whenever you have rhinitis, there is excessive mucus production. This excessive mucus is trying to wash the irritant off of the nasal mucosa. This leads to nasal congestion and postnasal drip, which is that drip down the back of your throat that may give you a sore throat. The nasal mucosa is continuous with the mucous membranes of all of the respiratory system, so sometimes rhinitis turns into something more severe as this progresses down into the respiratory system. Also, the nasal mucosa is continuous with the lacrimal ducts or the tear ducts, so sometimes inflammation from the nose spreads into the eyes and you get conjunctivitis. The membranes of the sinuses are also continuous with those of the nasal membranes, so inflammation of the nose may lead to inflammation of the sinuses, which is sinusitis. As mucus is produced in the sinus cavities, it may block the drainage from the sinus cavities into the nasal cavity. As this blockage builds up and the mucus builds up in the sinus cavities, you get the sinus headache, the pressure. Because mucus is an excellent place to grow bacteria, anytime you have mucus sitting around stagnant, it's an excellent opportunity for infection to occur. The pharynx is also known as the throat. It connects the nasal cavity and mouth to the larynx and esophagus. It is primarily a muscular wall and it is skeletal muscle, so this is under voluntary control. It can be divided into three parts. The nasopharynx is behind the nasal cavity. This is only a passageway for air. The eustachian tubes open here. The oropharynx is behind the mouth, so food and air can be in this compartment. And the laryngopharynx is just over the larynx. Food and air can also be here. The respiratory and digestive passages diverge at the larynx, so the trachea and the esophagus separate here. If we look at the pharynx, the nasopharynx immediately behind the nose, the oropharynx immediately behind the mouth, and then the laryngopharynx coming down just by the larynx. The larynx is the first part of the lower respiratory system, however, it is still part of the conducting zone. It's also known as the voice box. It functions to maintain a patent or open airway. It's also the place where we switch between the esophagus and the trachea. So this is where food goes into the esophagus or air goes into the trachea. And because the vocal folds are housed in the larynx, this is the site of voice production. The larynx is composed of 9 cartilages. 3 are unpaired, the thyroid, the cricoid, and the epiglottis. The other 6 are paired cartilages, the paired arytenoids, cuneiforms, and corniculates. If we look at the larynx, it's attached to the hyoid bone by the thyrohyoid membrane. The thyroid cartilage is the large signet ring cartilage. In males, this is quite prominent and makes up the Adam's apple. And then we have the cricoid cartilage. In between is the cricothyroid ligament. This is the area you want to penetrate if you're trying to do a tracheostomy. This will be below the vocal folds so that you won't damage the voice box. The other cartilages are housed inside the larynx, and here you can just see the epiglottis peeking over the top. If we look at it from the side, the epiglottis is an elastic cartilage. It extends from the tongue to the rim of the thyroid cartilage. So this is the front. So here's the front of the thyroid cartilage, the cricoid cartilage here. The back of the tongue would be here. So here's the epiglottis, ready to cover the opening to the trachea, which is known as the glottis. When air is flowing into the larynx, the airway is open. This means the glottis is open. The glottis is the opening to the trachea. During swallowing, the larynx is pulled upward and the epiglottis covers the glottis. This keeps food out of the lower respiratory tract and diverts it backward into the esophagus. If anything other than air gets into the larynx, it triggers the cough reflex. Housed in the larynx are the vocal folds. They vibrate to produce sounds. The length and thickness of the folds determine the pitch of the sound, and the force of air through the vocal folds determine the loudness. The vocal folds are controlled by tiny muscles that control the cartilages, primarily the arytenoid cartilages, that are attached to the vocal folds. Here we see the glottis closed. The epiglottis has been pulled back, and here the glottis is open. The vocal folds are here and here. Laryngitis is an inflammation of the vocal folds. This can lead to hoarseness or loss of the voice altogether. Viral infections are a common cause, but so is overuse, exposure to dry air, bacterial infections, tumors on the vocal folds, and the inhalation of irritating chemicals. The larynx also has a sphincter activity. The vocal folds will close during abdominal straining. So when the abdominal muscles are contracted, intra-abdominal pressure rises. This is called Valsalva's maneuver. It helps with emptying the rectum. It also helps stabilize the body trunk when you're lifting heavy items. The trachea is also known as the windpipe. It extends from the larynx to the division to the bronchial tubes at the mid-thorax. The trachea is held open by C-shaped cartilage. The opening is toward the back against the epiglottis. This allows the epiglottis to expand slightly without crushing the trachea. The mucosa of the trachea is covered with a pseudostratified columnar epithelium which is ciliated. The cilia move and help bring mucus to the mouth. This is known as the ciliary escalator. The mucus that is produced all throughout the respiratory system traps bacteria and foreign material to keep it from getting into the lungs. The cilia simply move that upward to the mouth so you can either spit this out or swallow it. The cilia are one of the first casualties of smoking. If the cilia are gone, chronic bronchitis typically develops. Here you see the C-shaped cartilage. This is the esophagus behind it, so there's a muscle here that helps prevent the esophagus from pushing the trachea closed. And here are the little cilia that line the trachea. This is exactly what they look like. Here's that pseudostratified columnar epithelium, and there are the cilia on it. The very last tracheal cartilage is known as the carina, and it's sort of heart-shaped because it's going to divide to the right and the left bronchi. The carina is very sensitive. If anything touches it, violent coughing is going to ensue. If the trachea is blocked, this means that air is not getting to the lungs. This is a life-threatening condition. The Heimlich maneuver, or the abdominal thrust, was developed to clear the trachea. Here you want to increase thoracic pressure to dislodge the blockage in the trachea. You really should do this by thrusting on the abdomen, forcing the abdomen to push the diaphragm up to increase the thoracic pressure. People sometimes die of what are known as café coronaries if they get something lodged in their trachea. They die because they can't breathe. The bronchial tree is so called because the trachea divides into two branches, the right and left bronchi. These are the primary bronchi. The right bronchus is wider, shorter, and more vertical than the left. This means that anything that's aspirated into the respiratory system is much more likely to end up in the right lung than in the left. This is true for items as well as fluids that may be aspirated that will cause aspiration pneumonia. The right and left bronchi divide into lobar or secondary bronchi. These supply the lobes of each lung. The right lung has 3 lobes and the left lung has 2 lobes. These further divide into the segmental or tertiary bronchi, which continue to divide into smaller and smaller tubes that are called bronchioles. Eventually we get to the terminal bronchioles. The terminal bronchioles feed the alveoli. So as we look at the respiratory tree, the trachea comes down and we have the right and left bronchus. We have our primary bronchi to the lobes. Then we have our tertiary bronchi and down to the tiny, tiny last little bronchioles that feed the alveolar sacs. The 3 lobes on the right side and the 2 lobes on the left side. The respiratory zone is where the actual gas exchange occurs. This occurs in the thin-walled air sacs that are known as the alveoli. The terminal bronchioles feed into respiratory bronchioles, and the alveoli protrude from these respiratory bronchioles. These lead into alveolar ducts. The alveolar ducts lead to terminal clusters of alveoli that are called alveolar sacs. Now the alveolar sac is like a bunch of grapes, and an alveolus is an individual grape in the cluster. So if we look at a section of the lung, and this would be microscopic, we have the terminal bronchiole branching into the respiratory bronchioles to the alveolar ducts. Here you see the alveolar sacs, and each one of these little balls is an alveolus. The lung is mostly air, so when you look at the lung, there's a lot of empty space and just a little bit of stroma or cellular material. So you're seeing respiratory bronchioles, alveolar ducts, and the cross sections of the alveoli and alveolar sacs. Each alveolus is connected to other alveoli through these alveolar pores, so none of these are entire upon themselves. The wall of each alveolus is a single layer of squamous epithelial cells. These are called type 1 alveolar cells. The alveoli are surrounded by fine elastic fibers which help it recoil after it's been inflated, and the external surface is densely covered with pulmonary capillaries. The type 1 cells and the capillary epithelial cells fuse to the same basement membrane. This is what makes up the respiratory membrane. It's very thin, only 2 cells thick with the tiny basement membrane between them. This allows for easy diffusion of oxygen and carbon dioxide. This is where external respiration occurs. Oxygen moves from the lung to the blood, and carbon dioxide moves from the blood to the lung by simple diffusion. As we look at an alveolar sac, we see the elastic fibers that surround each alveolus, and then you see this spider web of capillaries, again surrounding the alveoli. The respiratory membrane, besides being made of type 1 alveolar cells, has a few type 2 alveolar cells scattered in between. The type 2 alveolar cells secrete something called surfactant. Surfactant reduces surface tension. Alveolar fluid is mostly water, and water has a very strong attractive force for itself. This would mean that in these little tiny sacs, if we didn't have something that made it a little less sticky, we would have the sacs collapsing every time the air came out of them. This surfactant keeps the alveoli from collapsing because it reduces the surface tension of the alveolar fluid. As I showed you earlier, alveolar pores connect all of the adjacent alveoli. This allows air to move from alveolus to help keep the air pressure equal in the lungs. It also provides alternate air routes in case some of the alveoli become damaged or the bronchi become blocked. Alveolar macrophages, which are a permanent part of the lung, crawl freely through the alveoli. They kill bacteria that enter the lungs. This means that there are a lot of dead macrophages hanging out in the lungs that need to be swept out by that ciliary current. It's estimated that we clear and swallow about 2 million alveolar macrophages per hour. Here you see a cross-section through an alveolar sac. Most of the cells are the type 1 alveolar cells that are making up the respiratory membrane with the capillary membranes. The green ones are the type 2 that secrete surfactant. And the blue cells are the macrophages that are wandering through the alveoli picking up any stray material that shouldn't be there. The respiratory membrane is that fused alveolar epithelium with the capillary epithelium, giving a very thin membrane for the exchange of gases between the blood and the alveolar sac. The lungs occupy the thoracic cavity along with the mediastinum and the heart. The thoracic cavity is lined with the pleural membrane, but each lung has its own pleural sac. The lungs are attached to the mediastinum by the bronchi and the blood vessels. This is known as the root of the lung. The costal surface of the lung is against the ribs, and the hilum is a lung indentation on the mediastinal surface. Because the heart projects a little bit to the left, on the left lung there is an indentation called the cardiac notch that the heart fits into. The right lung has 3 lobes and the left lung has 2 lobes. So looking at this cross section, you see the heart in its own little pericardium, and then you see the right and the left lung, and each one has its own pleural sac around it. Okay, here's the esophagus going down through the mediastinum. This would be the mediastinum area. Then looking at the lungs, the right upper lobe, the right middle lobe, the right lower lobe, the left upper lobe, and the left lower lobe. Here is the cardiac notch where the heart fits into the left lung. Here's your mediastinum, the trachea coming down. And this would be the costal surface of the lung pushed up against the rib cage. Each lung is made of several pyramid-shaped structures that are separated from each other by connective tissue. The right lung has 10 of these. The left lung is variable, having 8 to 10 of these lobes. Each segment is served by its own artery, its own vein, and its own bronchus. This would be a tertiary bronchus. It's clinically important that we have this division because the connective tissue helps wall off each segment. If there's pulmonary disease, frequently it can be confined to one or a few of the segments. The connective tissue partitions also allow damaged segments to be surgically removed without having to damage the entire lung. The pulmonary circuit are the capillaries that cover the alveoli. We've said repeatedly that the pulmonary circuit is strictly for gas exchange. Bronchial arteries branch from the aorta and enter the lung at the hilum. They provide the lung tissue with oxygen and nutrients. Now, most of that blood drains back into systemic veins, but there are several anastomoses between the pulmonary circuit and the systemic circuit, so some of the blood does drain back into the pulmonary circuit. The lungs are innervated by the autonomic nervous system with fibers from both the sympathetic and parasympathetic system. The parasympathetic system will constrict the bronchial tubes. The sympathetic system will dilate the bronchial tubes. The pleura line the thoracic cavity and cover the lungs, each lung having its own individual pleura. The parietal pleura lines the thoracic cavity, and the visceral pleura covers the lungs. They produce pleural fluid, which lubricates the lung, allowing the lung to move freely against the thoracic cavity, but it also provides surface tension, keeping the parietal and visceral layers stuck to each other. The compartmentalization of the lungs helps prevent the mobile organs, the heart and the lungs, from interfering with each other. It also limits the spread of disease. Disease in the right lung will not necessarily travel to the left lung or to the heart. Pleurisy is a condition where the pleura are inflamed. The pleura become rough, the fluid becomes excessive and very thick and sticky. This means that the lungs do not move freely inside the thoracic cavity. Every time you breathe, it's like ripping off a scab. Sometimes other fluids accumulate in the pleural space, exudates. This is called pleural effusion, and the more fluid you get in there, the harder it is for the lungs to expand. Air is a fluid just like blood was a fluid, and just like blood, air is going to travel along a pressure gradient. So we need to talk about some of the pressure relationships inside the thoracic cavity. We always describe air pressure relative to atmospheric pressure. At sea level, atmospheric pressure is 760 millimeters of mercury. We say that that is 1 atmospheric unit, or 1 atmosphere. Anything below atmospheric is said to be negative respiratory pressure, and anything higher than atmospheric is said to be positive respiratory pressure. The intrapulmonary pressure is the pressure inside the lungs, the pressure in the alveoli. This pressure changes, but it always equalizes to atmospheric pressure because basically the inside of the lungs is continuous with the atmosphere. Intrapleural pressure is the pressure in the pleural cavity. Again, this will change with breathing phases, but we need to keep it about 4 millimeters below atmospheric pressure, or 4 millimeters below intrapulmonary pressure. Intrapulmonary pressure, as we've said, will always equalize with atmospheric pressure. There are forces on the lungs that tend to cause it to collapse. The lungs are very elastic, so once they have been blown up, they have a tendency to recoil, much like a deflating balloon. The alveolar fluid of the alveoli has surface tension. Surface tension is that attraction the molecules of the fluid have for each other. Because alveolar fluid is primarily water and it has a high surface tension, this tends to cause the alveoli to collapse. Surfactant helps prevent this from happening. But both of these are lung collapsing features. These are opposed by the elasticity of the chest wall. Your muscles and the cartilage that attach the ribs to the sternum help pull the lungs back out. In a healthy individual, neither of these forces overwhelms the other. There is a strong adhesive force between the parietal and the visceral pleura because of the pleural fluid between them. It allows the pleura to slide over each other, but keeps them stuck to each other. For this to work, the fluid must remain minimal. There just has to be a little bit. If you've ever stuck two glasses together, two wet glasses together, you know how hard it is to get them apart. But if you can get more fluid, if you stick the glasses together while there's a lot of fluid in them, they don't stick like that. This is how the pleura works. Pleural fluid is constantly formed, so it must be constantly removed, and it's removed by the lymphatics. It is the transpulmonary pressure, the pressure difference between the intrapleural and the intrapulmonary, that keeps the lungs from collapsing. This has to remain negative. Here you can see that the atmospheric pressure is the same outside as inside the lungs. The transpulmonary pressure is 4. That's the little bit of difference between the intrapulmonary pressure and the intrapleural pressure, about a -4 millimeters of mercury. Because the two pleura stay stuck to each other, and because of this negative pressure, the atmospheric pressure, tends to keep the lung inflated and pushed against the pleural cavity. Atelectasis is lung collapse. This can happen if the bronchioles become plugged. Any of the associated alveoli will then collapse when the air has been absorbed out of them by the blood. Or it can occur when air enters the pleural cavity, either through a chest wound or a rupture of the visceral pleura. Either of these will allow air from the respiratory tract to enter the pleural cavity. When you have air in the pleural cavity, that's known as a pneumothorax. In order to fix this, you have to draw the air out of the pleural cavity with a chest tube so that the lung can reinflate. So here is puncturing the parietal pleura, letting air from the outside in, or a tear in the visceral pleura. Now, this does not have to be from any kind of traumatic injury. Very tall people sometimes have problems with this. If they just stretch the wrong way, they can get a lung to collapse. Either way, air gets into the pleural space, and as the pressure in the pleural space becomes the same as that in the lung collapses. You have to remove this air, and that allows the lung to reinflate. Pulmonary ventilation is the first of the respiratory processes. This is inspiration and expiration. It's mechanical, and it depends on volume changes in the thoracic cavity. When you change the volume of a container, you change the pressure of the gas in the container. Fluids, or gases, move along a pressure gradient. The thoracic cavity is a closed cavity. Boyle's law states that as volume increases, pressure of the gas in the container decreases. Gases always expand to fill their container. For inspiration to occur, we have to increase the volume of the thoracic cavity, and we can do this if we can increase the dimensions of the thoracic cavity. As we increase the volume, we'll decrease the pressure inside the lungs, and that will allow air to flow in due to the decreased pressure. We will have established a pressure gradient. Expanding the thorax involves using muscles. When the diaphragm contracts, it flattens out. The thoracic cavity lengthens. When the intercostal muscles between the ribs contract, the ribs are pulled up and the diameter of the thoracic region increases. These make very small volume changes, but it increases the volume about 500 milliliters, and this is exactly the amount of air we take in during normal quiet breathing, what we call tidal breathing. So here we see that the diaphragm flattens out, lengthening the thoracic cavity. The intercostal muscles will pull the ribs up and out, increasing the diameter, and that will decrease the pressure, allowing air to flow inward. Expiration is a passive process in healthy individuals. Lung tissue is pretty elastic, so once we're no longer pulling on the muscles, they relax, the lung tissue recoils. The inspiratory muscles return back to their resting length. The rib cage descends, the lungs recoil, the thoracic volume decreases, increasing the pressure, and the air flows out. Forced expiration is an active process. It involves contracting the abdominal walls. When you increase the intra-abdominal pressure, you force the diaphragm up even higher, decreasing the size of the thoracic cavity even more. You also pull the rib cage down more, decreasing the diameter of the thoracic cavity even more. As we see in expiration, when the muscles relax, the diaphragm bows back upward, the ribs fall back to their normal position. That decreases the space, increases the pressure, and air is forced out. There are some air movements where we move air and we modify normal respiratory rhythm, but we're not really involved in exchanging gases. Sneezing and coughing are reactions that help clear the passages. They're usually in response to some irritant in either the nose or the throat. When you laugh or you cry, you're moving air, but you're not exchanging gases. These are emotional responses. Hiccups and yawns are reflexive but non-respiratory air movements. There are physical factors that influence ventilation. One is airway resistance. This has to do with non-elastic force. Just like with blood, resistance decreases airflow. Resistance decreased blood flow in the blood vessels. And just like in the circulatory system, this is mostly determined by the diameter of the passages. Now, the conducting zone diameters are very large. As the air tubes get smaller, there are more and more branches, so we have that increased total cross-section like we had in the capillaries. At the very terminal bronchioles, the gas flow stops, but that's okay because we've gotten the gas to the alveolar sacs and diffusion is going to take over. Surfactant is an important factor influencing ventilation. Surfactant reduces the surface tension of water. Since water molecules are polar, they're strongly attracted to each other. Surfactant keeps water from pulling the alveoli closed. If the alveoli stay partially open, it's going to take less energy to expand the alveoli. Deep breathing increases the production of surfactant, so the more we deep breathe, the more surfactant we have. Asthma is one of the homeostatic imbalances of the respiratory system. The smooth muscle of the bronchioles are very sensitive to neural controls and to certain chemicals that we'll call irritants. The parasympathetic nervous system will constrict bronchioles to protect the lungs from these irritants. Histamine and other inflammatory chemicals will also stimulate bronchiole constriction. This is what can happen in an asthma attack. Because the bronchioles are constricted, we can't move air in or out. Epinephrine will reverse the process and open the bronchial tubes back up, but if the bronchioles are constricted, we can't move air. This means that someone with constricted bronchioles will not respond to resuscitative efforts. If there's not enough surfactant, then the alveoli have to be reinflated during each inspiration. Think about those little tiny balloons that you sometimes get to make water bombs with. When you try blowing those up with air, they're very, very, very hard to blow up. Now imagine getting one of those wet on the inside and letting it collapse down, and then trying to blow it up. This is what the alveoli are like. They're like little tiny balloons. Once you get them inflated, it's pretty good. But if you have them wet and you let them deflate and they stick together, they're very, very hard to blow up. It requires a tremendous amount of energy to do that. Infant respiratory distress syndrome, or IRDS, is something that is frequently a problem with premature babies. Because infant lungs don't have to work until they're born, really, the lungs are one of the last things to develop. Those surfactant-producing cells don't come into play until late in fetal life. So babies that are born too early don't produce surfactant. This means that the first time they inflate their alveoli, which takes a lot of energy, they have to use that same amount of energy every time they breathe. This is too much energy for them to produce and stay alive. We can now treat this by either spraying natural or artificial surfactant in the baby's lungs, and this helps them survive. Bronchopulmonary dysplasia is a chronic lung disease that's seen in IRDS survivors. It's believed to be caused by inflammatory injury that happens when the mechanical inflation of the newborn's lungs damages the lungs. Just like we had aortic compliance, we have lung compliance. This is the ability of the lungs to be stretched and then returned back to their original shape and size. This helps with ventilation efficiency. If we can stretch the lungs and then they can snap back, that helps force air out of the lungs and we can reinflate them later. If we have low compliance, that is, if the lungs are not very stretchy, then it's going to take more energy for us to open them up. It takes more energy for ventilation. Lung compliance is determined by how stretchy the lungs are. This depends upon the elastic fibers. And there are lots and lots and lots of elastic fibers in the lungs, so this should be very high in a healthy individual. The other thing is the alveolar surface tension. And if you're producing an adequate amount of surfactant, the alveolar surface tension should be low. A loss of compliance will diminish ventilation efficiency. In chronic inflammations or infections, you may get scar tissue, and we know that fibrous tissue does not stretch like elastic tissue. If there is a decrease in surfactant production, then your alveolar surface tension goes up. That also makes it harder for the lungs to operate. Smoking is one of the things that will decrease surfactant production. The compliance of your thoracic wall is also a factor in ventilation, and as you age, the costal cartilage that hold the ribs to the sternum get less flexible, so the rib cage becomes less compliant. Respiratory volumes and capacities are simply measurements of how much air comes in and out of the lungs under certain conditions of expiration and inspiration. They can be measured with a device called a spirometer. This used to be a very large, cumbersome device. Now they have smaller mechanical devices that do the same thing. Respiratory volumes and capacities can be used to evaluate respiratory status. The values are often abnormal in people with respiratory disorders. We can use this to evaluate the effectiveness of a treatment or the progress of a disease. There are 4 respiratory volumes. Tidal volume is the amount of air you move during normal, quiet breathing. This is about 500 milliliters. Your inspiratory reserve volume is the air that you can forcefully inhale after you've taken a normal breath in. Usually you can take in a lot more air than you take in normally, somewhere between 2,000 and 3,000 milliliters more. The expiratory reserve volume is the air that you can forcefully push out of your lungs after you've exhaled normally, around 1,000 milliliters or so. And the residual volume is the air that remains in your lungs. Since your alveoli don't completely collapse, there's always a little air in the alveoli. This is your residual volume. Respiratory capacities are sums of the various respiratory volumes. Your inspiratory capacity is all the air that you can inspire, so that would be the tidal volume plus the inspiratory reserve volume. The functional residual capacity is all the air that's in the lungs after a normal tidal expiration, so that would be the residual volume and the expiratory reserve volume. The vital capacity is all the air that can be exchanged, so that's the tidal volume, the expiratory reserve volume, and the inspiratory reserve volume. And your total lung capacity is all the air the lungs can hold. So that's your vital capacity plus your residual volume. This shows some of the capacities and volumes. Notice that normal tidal breathing, just a small amount of air that the lungs can move is moving. If you're really taking in air, you can take in a lot. If you really want to blow air out, you can blow out more. Everything you can inspire is your inspiratory capacity. Everything that stays in your lungs after a normal exhale is the functional residual capacity. Everything you normally can possibly move is your vital capacity, and all of the air that can be in your lungs is your total lung capacity. There is always a little bit of dead space, some air that's never available for gas exchange. Most of your dead space is anatomical dead space. You've always got some air in the conducting passages that never make it to your lungs, so it's not available for gas exchange. A rough estimate of your anatomical dead space is about 1 milliliter for every pound of ideal body weight. So if you're overweight, it's not your entire weight, just what your ideal weight should be. Alveolar dead space should be minimal to non-existent. This is when alveoli cease to act in gas exchange. This would mean that you had damaged alveoli or blocked bronchial tubes. Alveolar collapse or mucus obstruction. In a healthy person, this should be minimal if at all. Your total dead space would then be the sum of your anatomical dead space and your alveolar dead space. Pulmonary function tests cannot diagnose but can distinguish the different types of pulmonary diseases. Obstructive pulmonary disease, you have increased airway resistance. In restrictive diseases, you have reduced lung capacity. Pulmonary function tests can help assess treatment and can follow the course of diseases. In obstructive diseases, your total lung capacity, functional residual capacity, and residual volume may increase. Because you have trouble getting air out, the lungs tend to hyperinflate and you hold more air in. In restrictive diseases, the vital capacity, total lung capacity, functional residual capacity, and residual volume decline. Here the lungs cannot expand as much as they should, so you don't take in as much air. Another pulmonary function test is one that assesses the rate of movement. The forced vital capacity measures the amount of gas you can forcefully expel after you've done a very forceful inhale. That is, you breathe in as much air as you can and then you blow it out as fast as you can. The forced expiratory volume is a measurement of the amount of air expelled during specific intervals, usually every second. The FEV1 is the amount you expel in the first second. For a healthy individual, about 80% of your forced vital capacity should be expelled in the first second you're exhaling. In obstructive pulmonary diseases, the FEV1 is less than 80%. In restrictive diseases, the FEV1 is normal or greater than 80%, but the forced vital capacity is reduced. Your minute respiration is the amount of gas that flows in and out of your lungs in 1 minute. At rest, that's about 6 liters. If you assume that your tidal volume is about 500 milliliters and you breathe about 12 times per minute, 500 times 12 is 6,000 milliliters or 6 liters. When you're doing vigorous exercise, you may move as much as 200 liters of air in and out of your lungs. The alveolar ventilation rate is a better index of how much gas exchange you're having. The alveolar ventilation rate can be calculated by taking the frequency of your breathing, how many breaths per minute, and multiplying that by your tidal volume minus your dead space. Your dead space should be relatively constant and should constitute only that conducting space, which remember is your ideal weight in milliliters. If you increase the volume of your breathing by taking deeper breaths, then you increase your alveolar ventilation rate and you increase your gas exchange. As your dead space approaches your tidal volume, then effective ventilation reaches zero. For people who have lung diseases that add to their alveolar dead space, they can get to the point where they're not ventilating well at all. If you've ever gone snorkeling, you may find yourself getting breathless kind of easily because that snorkel tube has added to your dead space.